Hi, I'm Dave Lockwood. I'm a respiratory therapist and clinical specialist for Percussionaire Corporation. Since the start of the COVID-19 pandemic, Percussionaire has been receiving many inquiries from facilities asking if our IPV therapy or our VDR ventilator has shown any effectiveness with COVID-19 patients. And the answer is yes. But we thought it would be helpful for you to hear directly from some of our more experienced users of IPV and the VDR ventilator. I'd like to now introduce you to a series of one-on-one interviews we did with advanced practice clinicians from different facilities throughout the United States and from Europe. These clinicians have been using both the IPV therapy and/or the Percussionaire VDR ventilator in treating COVID patients. They will discuss how they've been using the devices, what settings they've been using, and how COVID has changed how they use the devices. We designed this series so that you can watch each individual interview and watch them at your leisure. We hope you will find these to be helpful. Today, I'd like to introduce Bob Terrell. Bob, tell us a little about your background.
Thank you, Dave. Like you, I'm an RT. As far as background is concerned, I've been doing respiratory care since 1992. Have used the Percussionaire products since the mid-90s, and more recently in 2009 to 2010, started using the VDR. Currently, I work as a territory manager for CENTAC for the state of New York, but I still like to do respiratory care, so I still work on the weekends in a hospital. That's what I currently do.
So have you been using both the IPV and the VDR, or one of the devices in particular?
Correct, both. IPV since the mid-90s to late 90s until now, and the VDR since 2010, around 2009 to 2010.
And have you been using them since the beginning of the COVID pandemic, or at what point did you elect to start using these devices with COVID-19 patients?
About a month to a month and a half into the first wave when we got hit. So that'll be around April of 2020 when we started using the IPV on the floors to prevent patients from progressively getting worse while they're on high flow or BiPAP, and the VDR as kind of a rescue type of approach before they end up qualifying for ECMO.
Okay. Can you talk more about the control when you had IPV therapy and you were doing it with high flow nasal cannula patients? How long were you doing the therapy for? Was it easy for the patient to start using it, or did you have to kind of work into settings that were good for them, and what were the results of the treatment?
Yeah, it did vary. Some patients did very well with it. They can do mouthpiece. Many of them use the mask, which is a non-vented or the blue elbow mask, BiPAP mask, and did pretty well with it, while some patients do not tolerate, become short of breath, and prefers not to continue. So it really varies, but we've had good success with many patients. We've also had a share of not so successful ones, the ones that didn't really tolerate it. And the therapy duration can range between 15 to 20, 25 minutes per therapy.
What did you use as indicators for the therapy? Did you look for improved saturations post-therapy? Did you see patients coughing up a lot of secretions? Or do you think it was mostly with re-recruiting the FRC with the IPV therapy?
And the indication basically are for those patients that are on increasing amount of flow rates required for high flow and FiO2s. What does that mean? We're looking at, we'd like to think we get to start them around 60, 70, 80%. Oftentimes we don't even get to start it until about 90, 100%, where they're already on maxed out settings. The same goes with patients on BiPAP. If we get the opportunity to do it when we notice there's an increasing amount of support particularly the FiO2, with the saturation continues to go down, we'd like to start them on IPV to do lung recruitment. Mainly for lung recruitment, they do cough. Some of them even go to a vigorous coughing, but not necessarily at that point getting a lot of secretions out. It seems to be just mainly for restoring lung volume.
And you mentioned 15 to 20 minutes treatment. How often will you do them? Were you Q6, Q8, Q4? And with the patients that you were successful with, how long did you have to do treatments before you decided they were low enough on their high flow nasal cannula, or perhaps off of it and back to a standard nasal cannula? Any thing there?
The frequency we do recommend with physicians between every 6 to 8 hours, and but the duration between 15 to 25 minutes, depending on some patients again tolerate longer, some patients don't. So we do make sure that we prioritize, or we focus on tolerance first, so they will again repeat the procedure. Some patients respond within 4 to 6 treatments. Some patients respond between 12 to 18 treatments. It really varies from patient to patient. And we've had patients where he was so severe. He's a pretty young guy. He was in his 40s, on the floors, desatting progressively, now even on not just on high flow, but on a non-rebreather mask. And I'm sure people would laugh at this, but a lot of us do it because we're so desperate in keeping them oxygenated. He wasn't showing significant amount of shortness of breathing, because I guess because he looks so young and he can sort of pace his breathing, but he was really significantly desatting. So we just started him on IPV, and just a couple of treatments. He was showing some improvement, but it was kind of too late to stop the transfer to the ICU. He was already being decided to transfer, but he didn't stay too long in the ICU. Less than 48 hours, he was shipped right back to the floors, because he did respond eventually and recruited. So some are very fast, some would take a couple of days, and some would just not even respond at all, and they would still end up getting intubated.
Okay, with the IPV therapy, a lot of people are concerned with aerosolization. I know what I've done with my patients. What did you do as far as protecting of yourself when you were doing IPV with these patients? Were you in a negative pressure room, etc.?
Yeah, we do strictly follow all the recommendations, the guidelines, to ensure safety, not only for patients, but obviously for the employees and others who may enter the room. So one, a patient has to be in a negative pressure room before we even consider therapy of IPV. And two, we filter ports, okay? And three, if we can use the mask and they can tolerate, we use the mask to sort of minimize any other aerosol escaping, and of course full protective gear, PPEs for employees. While the therapy is going, we discourage people from going in at that point, just again to just minimize as much as possible any possible aerosol exposure. Of course, in the beginning, it was kind of a no-no from a hospital point of view because of the concern about aerosol, but we've had we're working with excellent physicians who are also looking at the other picture of saying, if we take all precautions just to be able to achieve full benefits with IPV and lung recruitment, can we do that? And it was agreed upon to go ahead and proceed with the procedure, as long as everybody follows those safety guidelines.
Points well taken. And I remember my experience too, when people were worried about aerosolization. I said, well, when we're in a room with a patient with COVID or any other airborne disease, we don't seem to worry if the patient has to cough. And I put it similar to doing an IPV treatment. And as you said, we did the vast majority of our treatments with a mask, so we didn't have to worry about a patient with maybe occasionally a poor lip seal on the mouthpiece. That way we were capturing both that, preventing that, as well as anything through the nose. Anything else you'd like to add about IPV, or would you like to talk about your experiences with VDR now?
Like the VDR, I think the earlier you initiate the application, the better as far as recruitment potential. What we found is this is definitely a heterogeneous type of disease where percussive ventilation is more useful than pressure ventilation. So that's something that I guess we need to really consider with the clinical team.
Can you go tell us a little bit more about your experiences with the VDR in COVID patients? Can you touch on, I know I've had some other high users say that they waited till they were in rescue mode, but they saw good results. And so some of our other future guests have talked about their policy is if they have a VDR available and they have a COVID patient there, starting them right from the beginning on the VDR. What has been your experience?
We've had a mixed bag, even though we do want to start as early as possible. Many of our patients do respond well on conventional mechanical ventilation, at least for some time, where it gives the clinical team hope that if we stay on track, we should be able to get out of this. And for many, yes, they do, but for some, they don't. After about a week or two, they deteriorate. That's when VDR is decided. So it's not like we don't want to start it sooner, it's that the patient is doing well. And so we ended up doing a rescue when they're already in about, say, 8 to 12 days later. But those patients that we've started within the 24 to 72-hour period has done really well. For some reason, they respond very quick. We get to transition them right away to conventional mechanical ventilation, and we typically wean from conventional. We don't wean from the VDR, we wean from the conventional into a typical spontaneous SBT type of weaning procedure.
When you say they responded quickly and you went back to conventional vent, could you summarize how many days they were probably on the VDR before switching back and then able to start the weaning process on the conventional vent?
Yes.
And also I was curious, with your COVID patients, I've had many clinicians that used to use a cuff leak technique routinely, and they have decided with COVID patients not to use the cuff leak. Many of our facilities never use a cuff leak unless carbon dioxide or secretions are an issue. So with your experience, have you been using leak or not leak?
No leak at all. First of all, we're not unless there's significant amount of copious, thick, large amount of secretions or soot in a burn patient, then a leak is considered. But otherwise, our training with the VDR has always been closed system as best as possible. So we have full control over the mean airway pressures and pulsatile flow rate, not having to lose out energy by the leak.
Okay, and I apologize, I asked you two questions there, and I didn't give you time to answer about what your average length of time was on the VDR.
Oh yeah. For those that responds pretty well, we're looking at the first 4 to 6 days. We get them off back into conventional, and a couple of days of weaning thereafter. But some of the patients are just so difficult. Again, COVID is a very unique type of disease where our typical ARDS would typically have no lung volume. In fact, they would require tremendous amount of peak pressures in addition to tremendous amount of PEEP. COVID is quite unique. Yes, they may require some kind of PEEP between 10 to 15 or so centimeters of water pressure, but many of them don't even require that much driving pressure to deliver 4 to 6 ml per kg of tidal volume. So it's really different. The problem is if we try to work on those amount of volume and minute ventilation, often we find ourselves very hypercapnic in addition to already a hypoxemic patients. So that's when we start thinking about we should really make breathing more efficient by not only performing the same chest rise, but delivering percussive pulses to create exchanges of CO2, at the same time delivering fresh oxygenated gas into the lungs to be able to increase molecular diffusion. And as a side effect with the percussions, also recruit and mobilize secretions and recruit atelectasis. So all of those combined, and that's characteristic of a VDR, we feel could benefit far more if pressure-based or volume-based ventilation is not working, whether it's PRVC, pressure control, bi-level ventilation, or some folks use APRV with their Dragers. Certainly, sometimes you find yourself stuck and not be able to move forward. So we do use the percussive ventilation.
So if I understand you correctly, you're saying too with the VDR that you didn't need as high a pressures and as high as oscillatory PEEP as you would with a traditional ARDS patient?
Yes, that's correct. In fact, that is, there's a paper that came out from, I think 2019 from Duda and colleagues where they were able to demonstrate that on a test lung model and using, I believe it was nitrogen or trying to ventilate to be able to look at washout efficiency and time efficiency, comparing the same settings as conventional and high frequency ventilation, where you can create a good significant amount of washout with this technology compared to conventional pressure-based or volume-based. In that case, they're using pressure control as a comparison. And again, you could have the same driving pressures, but because you have percussive pulses penetrating the lungs at a very high frequency, you can make breathing a lot more, at least CO2 elimination, a lot more efficient.
Thank you. Very good. Have you had any instances with COVID where they were thinking possibly the patient would need to go on ECMO and you possibly started IPV or VDR on them and negated the need for ECMO? Oh,
yes, many times. And there's a combination. Some patients do respond and never had to progress into an ECMO. And some patients, unfortunately, will have to be transferred to an ECMO facility because we don't do ECMO at our hospital. So we have sister hospital, or we have surrounding hospitals in New York City who will take those patients if they are not also at capacity, because there were situations where we can't transfer the patients. So we ended up putting them on a VDR anyway as a rescue. And some of those patients got out of it, and some of those patients, unfortunately, we couldn't do anything. They really needed ECMO.
Okay. I know you wanted to show a couple of slides and videos at this time. Do you want to talk about those more?
Yeah, I want to enhance more about, there's always a question, again, as an RT, I'm always asked, so what makes, show me proof or some kind of illustration that percussive ventilation is different than the conventional form of ventilation, which is pressure-based or volume-based. So could you play that battle video? And many of the viewers have probably already seen this. And it's just something that I have created for the physicians that I work with to show that it's extremely difficult to ventilate a bottle. I don't know if you could replay this, Dave, from the start. I don't know if you can drag that, there you go. You can see right here that on pressure base, it's very difficult to ventilate a bottle because the bottle will not expand. So most of the pressure or flow would go to the path of least resistance. So I have two test lungs here teed in together. So now I am able to deliver PEEP and pressure on the nice rubber inflating lung. But as you can see, the bottle, because it will not expand, I filled it up with confetti, you will not see any gas movement. Contrary to that, when using percussive ventilation, not only that you're able to maintain the same amount of PEEP, the same amount of PIP, you will also be able to ventilate a bottle that otherwise cannot be ventilated with any other mechanical ventilation technology. And that's really what makes this device very efficient, not only in eliminating CO2, where you see that countercurrent flow of gas, but you'll also, of course, the current flowing out of a test lung or in an airway would now drive mucus or debris out away from the lungs out into the environment. And again, that's just a side effect. And the other benefit, of course, is that you have the ability to do both convective ventilation, which you see right there in the rubber test lung, as well as diffusive ventilation, which is again two unique or a very unique property of this technology, where you could do both convective and diffusive ventilation all at the same time. Again, making it a lot more efficient with respect to ventilation and or oxygenation.
I always found this very good representation, because unlike the conventional ventilator, where everything went into the rubber lung, which represents normal compliant lung, you can see here that not only are you ventilating the glass bottle, which represents the lower compliant, but if people notice, the rubber lung is still being inflated. And I think this is very good about showing the countercurrent flow that is created by the VDR.
And of course, this is not to underscore the complexity of a human lung. This is just to compare apples to orange type of ventilators. We're looking at two flow-based and pressure-based ventilation, and why when you get stuck and you're not really finding yourself moving forward with pressure-based ventilation or volume-based ventilation, maybe it's time to consider percussive-based ventilation or flow-based ventilation, so you can penetrate those areas of the lungs that are otherwise extremely difficult to ventilate with those modes.
I believe you had a chart you wanted to show about how you approach the waveforms with the VDR.
Right. Because, as I mentioned earlier, let me see if I could do a share screen. I'm going to make an attempt here. Let me see. As I mentioned earlier, can you see my screen now?
Started sharing, it says. Yep, I see it.
Okay. Because the VDR, or I'm sorry, the COVID disease is so unique, we try to really educate our team to be able to customize our settings based on the current condition the VDR is seeing downstream. And that's, again, another unique characteristic of the VDR, is that you can, even though the X-ray may show ARDS, which is typical ARDS, and COVID patients with ground glass appearance, opacities, with consolidations almost identical, the VDR actually can see the difference between the two, where your typical ARDS that we've been accustomed to would have significant spikes of pulses, which is a good example, as you'll see on the first one right here, first two, actually first three types of conditions, where the fasciatron sees significant amount of resistance downstream, representing very large spikes, right? What's unique about the COVID, even though they may appear clinically from the significant drop in the PF ratio, from chest X-ray, all other things that you could see between the similarities between the two, the VDR can actually show you that the lungs characteristic is not the same. In fact, what you'll see is that they're a little bit more sloped. Instead of a boxy waveform, they're a little bit more sloped, signifying there is lung volume, which means a clinician really have to be careful now, because you do have some lung volume that you can work with. Your goal is to preserve the integrity of those lung volumes, to continue to keep them from getting plugged up, from getting damaged, or injured, and by using lower pressures as best as possible and efficiently ventilating it with pulses. Because you can see not only that you have that sloping motion of the waveform, you will also see a much smaller amplitude. And it almost looks like this, although this is not representing what you would otherwise see on a COVID type of patients. But the waveform almost looks like that as when compared to these waveforms right here. A COVID actually would look a lot like this one, which is a mixed type of a heterogeneous type of conditions. And the chart basically sort of predicts what condition the patient will be with respect to blood gases. They're likely going to be poor oxygenation. CO2 is likely going to be high. Cardiac output may be okay, but depending if there's over distension or decreased venous return, you might, because of maybe increasing PEEP, may be poor. The X-ray may be slightly hyperinflated in some areas or over distended, but you will have some patchy infiltrates or ground glass appearance. Secretions may be copious. It sort of just gives our clinicians an idea of what to expect. At that point, how do I set my settings? What pulsatile flow rate will I be using? Because if the CO2 is high, I'll definitely be using higher pulsatile flow rate to penetrate the lungs to reach as deep as I can so I can ventilate it more efficiently with the pulses. I would have to use shorter I time because I can only have higher flow and shorter I time. If I use both, I'm going to end up over distending. Remember, the healthy areas of the lungs, or at least those areas that are still functional and we're able to ventilate. So the goal is always to be lung protective, prevent further injury, and preserve what we got, and at the same time percuss and recruit gently those areas of the lungs that has mucus plugs, atelectasis, and then just mobilize that using the countercurrent flow. The E time can be adjusted based on the amount of ventilation you want to achieve. I always try to explain this to respiratory therapists. When you're doing conventional ventilation and you want to increase ventilation, we increase the respiratory rate. In the background, you're actually dropping the expiratory time. So in this particular case, to increase ventilation with the VDR, we don't adjust the I time anymore. We've fixed the I time. We know what the appropriate I time is. We just adjust the E time. And in this case, to increase ventilation, we would drop the E time. And of course, oscillatory PEEP and combined demand CPAP would be whatever is appropriate to optimize FRC without having to overstand and drop the venous return, and consequently after that, hemodynamic compromise. And percussive rate, because the most common reason for the oxygenation or poor oxygenation here is due to mucus plugs and or atelectasis, we would tend to use lower percussive rate, less than 500, so we can have larger pulse volume to go into the lungs to be able to recruit them. If this was the case, such as an inflammatory condition, you'll see here on the first box, we would be using higher percussive frequency or rate because there's really nothing to recruit. It's purely a diffusive ventilation approach. So, and convective pressure rise we may consider because we have some areas of the lungs that are very difficult to reach with flow. Then we would consider convective pressure rise, or conservatively 3 to 5 centimeters of water pressure, just to be able to penetrate those areas that are otherwise cannot be reached by pulsatile flow rate alone. That could either be a 15-minute procedure, that could either be a 24-hour procedure, really based on what the doctor decides, which you can't use on the other type of condition because the convective pressure rise here would probably be more injurious than benefit because there's really no lung volume to inflate, okay? It's completely inflamed. So I just wanted to share this, that we do customize our care. Our settings are based on what we see, based on our assessment, what the waveform is showing, and of course, the other information is available clinically.
That's excellent, Bob. That's just an outstanding approach to ventilating a person in general, looking at the situation and customizing, I think, to the disease physiology rather than just to quote the patient. I think that's a brilliant idea myself.
Thank you. Yeah, we find that having the ability to customize the settings based on the disease condition really optimizes our success.